Well, good morning, and thanks to the Canadian Academy of Health Sciences for inviting me to give this lecture this morning. It is indeed a real honor for me. And odd as it may sound, I always appreciate the opportunity to talk about assisted dying. So I'm going to jump right in, as time is short, and my challenge is in this brief window of time is to provide you with an overview of assisted dying in Canada, past, present, and future, which is no small feat in 22 minutes. The first thing to do is to quickly make sure, though, that we're all clear on what we're talking about. So medical assistance in dying, this is now the official label in Canada, and this means the administering by a medical practitioner or nurse practitioner of a substance to a person at their request that causes their death. You may know that as voluntary euthanasia. It is also the prescribing or providing by a medical practitioner or nurse practitioner of a substance to a person at their request so that they may self-administer the substance and in doing so cause their own death. You will know that as assisted suicide. So with our terminology clear, we can move to a review of the legal status of medical assistance in dying. So first, the past, when it was clearly illegal. In the distant past, assisted dying was prohibited by the criminal code. Sue Rodriguez, a woman with amyotrophic lateral sclerosis, a degenerative neurological condition, challenged the prohibition under the Charter, but she was unsuccessful at the Supreme Court of Canada by the merest of 5-4 margins. There were also a number of failed attempts to pass legislation that would permit some assisted dying. There was also a special Senate committee on euthanasia and assisted suicide, but it too did not end up recommending changes to the law. Looking at the middle distance past, though, we can see a strong and increasing public support for decriminalization. There's been a majority support for assisted dying in Canada now for decades, growing ever stronger. We can also see a growing body of evidence from permissive regimes demonstrating that the feared slippery slopes have not materialized. There was also significant new Charter jurisprudence from the Supreme Court of Canada on various significant sections of the Charter, for example, introducing new principles of fundamental justice and thereby opening up the possibility of new arguments to be made to the court, such as the argument that the prohibitions limit more people's rights than is necessary to do in order to protect the vulnerable. And finally, an expert panel of the Royal Society of Canada on end-of-life decision-making recommended the decriminalization of assisted dying. Moving closer to the present, there were two monumental developments. First, Quebec engaged in a long consultative process, catalyzed by physicians, I should note, and ended up with an act respecting end-of-life care, which regulated medical aid in dying as a form of health care. This legislation came into force in December 2015, and there have been at least 60 assisted deaths since then. And second, in the rest of Canada, we were following the case of Carter v. Canada through the courts. Kay Carter was a woman with spinal stenosis who made the decision that her suffering had become too much, and she asked her family to take her to Switzerland for an assisted suicide. They did so, and they also became the first named plaintiffs in the case that would change the law in Canada. Then Gloria Taylor, a name that's probably more familiar to you, this was a woman with ALS who also wanted an assisted death. She joined the case. And then the British Columbia Civil Liberties Association, also representing many, many more suffering Canadians, effectively carried the case. The argument was that the criminal code prohibitions on assisted suicide and voluntary euthanasia violate the Canadian Charter of Rights and Freedoms. The plaintiffs were successful at trial. They lost on appeal, but that was only on the technical point that a trial judge is not allowed to overturn the Supreme Court of Canada, and the Supreme Court had ruled in Rodriguez. But then the plaintiffs were successful again at the Supreme Court of Canada. And the court ruled 9-0 that the criminal code prohibitions violated the Charter insofar as they prohibit physician-assisted dying for a competent adult person who clearly consents to the termination of life and has a grievous and irremediable medical condition, including an illness, disease, or disability that causes enduring suffering that is intolerable to the individual in the circumstances of his or her condition. And I would note, and this will become relevant later, irremediable, they added, does not require the person to undertake treatments that are not acceptable to them. And the court gave the government 12 months to February 6, 2016, within which to craft new legislation. If it chose to do so, I would note they actually had no obligation to pass legislation. And when the new Liberal government took office in November, they asked for an extension, and they were given 4 months, that is, to the infamous date of June 6, 2016, that you heard so much about last spring. In the meantime, 3 groups were tasked by various levels of government with studying the question of how best to regulate assisted dying, and 2 of the 3 were also tasked with making recommendations. A federal panel appointed by then Prime Minister Stephen Harper, a provincial territorial expert advisory group, and a special joint committee of the House and the Senate. They all issued reports, the latter 2 with recommendations. And the provincial territorial expert advisory group recommended, do not go narrower than Carter, do include mental illness, advance requests, and mature minors, do establish a duty to transfer care on conscientiously objecting healthcare providers. And the Joint Committee issued similar recommendations, varying only in recommending a 2-year delay in the coming into force of the permissive provisions with respect to mature minors. Ultimately, the federal government introduced Bill C-14 in April. A firestorm ensued, in no small part because the government did go narrower than Carter, did not include mature minors or advance requests, at least not yet, and did not establish a duty to transfer care. Although, to be fair, I would note this lies outside their jurisdiction, the last part. A furious federal parliamentary debate ensued. Attempts were made in the House to amend the bill to become less restrictive. They failed. The Senate sent an amended, less restrictive bill back to the House, but the House rejected the more permissive amendments. And finally, the Senate conceded and passed the House's more restrictive bill. So the legislation was passed and came into force on June 17, 2016. So here we are, with a law that is narrower than that recommended by the Royal Society of Canada Expert Panel, the Provincial Territorial Expert Advisory Group, the Special Joint Committee, the amendment sought by the Senate, and I would argue is narrower than that required by the substance of the Carter decision from the Supreme Court of Canada. So that brings us to the present. So let me run over the key elements of the federal legislation. So medical assistance in dying is the umbrella term that includes both voluntary euthanasia and assisted suicide. It is, by way of reminder, we saw this at the beginning, the administering by a medical practitioner or nurse practitioner of a substance to a person at their request that causes their death, and the prescribing or providing by a medical practitioner or nurse practitioner of a substance to a person at their request so that they may self-administer the substance and in doing so cause their own death. Recognizing the scarcity of physicians in Canada, especially in rural and remote communities, as well as the competencies and the accountability of nurse practitioners, both physicians and nurse practitioners are allowed to provide medical assistance in dying. Recognizing that healthcare is provided in teams and few physicians or nurse practitioners would be acting completely alone, and also recognizing that some patients would want their loved ones to be the ones to help them at the end, any person is permitted to assist the providers. So pharmacists, nurses, friends, and family members are all permitted to assist the person who actually provides the assistance. Recognizing that patients may well have a whole range of healthcare providers that they want to ask questions about assisted dying, and that these providers could be very appropriate sources of information. The law allows that information can be provided by social workers, psychologists, psychiatrists, therapists, medical practitioners, nurse practitioners, and other healthcare professionals. According to the new legislation, only those who meet the following criteria can have access to medical assistance in dying. Patients must be eligible for health services funded by the government in Canada, so that's avoiding the suicide tourism that people talk about. Must be at least 18 years old, be capable of making decisions with respect to their health, have made a voluntary request, have given informed consent to receive medical assistance in dying after having been informed of means available to relieve suffering, including palliative care, and have a grievous and irremediable medical condition. And here's where it narrows. In particular, this is further explained as they have a serious and incurable illness, disease, or disability. They are in an advanced state of irreversible decline in capability. That illness, disease, or disability, or that state of decline causes them enduring physical or psychological suffering that is intolerable to them and that cannot be relieved under conditions that they consider acceptable. And their natural death has become reasonably foreseeable, taking into account all of their medical circumstances without a prognosis necessarily having been made as to the specific length of time that they have remaining. Turning now from the eligibility criteria to key procedural safeguards, a medical or nurse practitioner must be of the opinion that the person meets all the eligibility criteria. Requests must be made in writing, signed, dated after the patient has been informed of their grievous and irremediable condition. 2 independent witnesses to the request, a second independent medical or nurse practitioner confirming that all the eligibility criteria have been met. Then there must be a 10-day waiting period between the day of the request was signed and the day medical assistance in dying is provided, unless death or loss of capacity is imminent. And the patient must be given the opportunity to withdraw consent and indeed must explicitly reconfirm the consent required immediately prior to the provision of medical assistance in dying. Conscience was, of course, the subject of enormous debate in relation to the legislation. The legislation itself says the following: nothing in the Act affects the Charter guarantee of freedom of conscience and religion, and nothing compels an individual to provide or assist in providing medical assistance in dying. Basically, this is all that the federal government has the jurisdiction to do. This issue really rests with the provinces and the territories. The legislation also provides for retrospective oversight. There's a duty to file information on every written request for medical assistance in dying. This is not yet enforced. We don't have data. Penalties for non-compliance with the legislation, and a parliamentary review of the provisions of the Act and the state of palliative care in Canada, which has to start by 2021. The legislation also imposes some obligations on the Minister of Health. She must make regulations on the provision, collection, analysis, and reporting of data. She must, after consultation with the provinces and territories, establish guidelines on the information to be included on death certificates. The legislation also provides that the Ministers of Justice and Health must, by December 17th of this year, initiate 1 or more independent reviews of the issues relating to mature minors, advance requests, and requests where mental illness is the sole underlying condition. And no more than 2 years after the initiation of the reviews, must present these reports, including any findings or recommendations, to both houses of Parliament. And finally, while not in the legislation itself, when it released the legislation, the federal government promised to increase support for palliative and end-of-life care and to work with the provinces and territories to establish a pan-Canadian system for access with 3 objectives: to facilitate transfers of care, to protect the conscience of objecting providers, and to protect the privacy of willing providers. So that's where we are from a legal perspective today. Now you might be wondering, well, what comes next? Well, next we have to face the challenges of implementing the legislation and dealing with several outstanding legal issues. We still need to sort out data gathering. What goes on medical certificates of death? What information needs to be reported and to who? Medical assistance in dying protocols. What drugs? What dosages? Who's going to pay for the drugs? For the services of the healthcare providers? How will the promised system for transfers of care in the face of conscientious objections be managed? And the education of healthcare professionals, lawyers, and the public, for example, medical, nursing, pharmacy, and law schools are going to have curricula. And the Royal College of Physicians and Surgeons, the Canadian College of Family Physicians, they will need to develop competencies and training programs, and the same goes for nurse practitioners, nurses, and pharmacists. And we must also, and this is particularly significant given the conversation yesterday, correct for a major failing in the work to date, and that is engaging Indigenous communities in implementation. Now, lots of groups have been very active, but there's clearly still lots to be done. There are also 2 key outstanding legal issues that have to be resolved, specifically conscientious objection and the eligibility criteria. First, we're going to have to get clear on whether healthcare providers have a legal obligation to inform patients about medical assistance in dying, to transfer care to a provider who's willing to conduct an assessment and provide assistance to the patient if they're eligible, and or to arrange an effective referral. We're going to have to figure out whether publicly funded healthcare institutions have a legal duty to transfer patients, or to allow the provision of medical assistance in dying within their walls, or in fact to provide medical assistance in dying. The battlegrounds for these issues will be health professional regulatory bodies revising their guidelines, provincial territorial governments deciding whether to introduce legislation to create statutory obligations for providers, and whether to insist upon provision by institutions through, for instance, their MOUs. Ensuring access to medical assistance in dying might even be made a condition of the transfer of federal funds under the upcoming health accord negotiations. And of course, litigation has already started as the Ontario College guidelines, which require effective referral, are being challenged in court by a consortium of religious groups. And patients too may litigate if it turns out that access is being severely hampered by the exercise of freedom of conscience by individuals or institutions. And recent news reports certainly suggest that this is happening. There is no good data yet. The second major outstanding legal issue concerns the eligibility criteria. The government chose to exclude mature minors, so those are individuals under the age of majority who nonetheless have capacity. Requests made in advance of loss of capacity, so principally persons with dementia, and it thinks it excluded individuals whose sole condition is a mental illness. They also baked some exclusions into the legislation by saying that medical assistance in dying is only available to those whose conditions are incurable, are in an advanced state of irreversible decline in capabilities, and whose natural death is reasonably foreseeable. There will be workarounds for one of the to-be-determined issues, specifically advance requests made by, for example, someone who has received a diagnosis of Alzheimer's. We will see those who can, that is, where their provincial territorial advance directives legislation allows, refuse food and water through advance directives. And that's how they will die. Others will seek medical assistance in dying or commit suicide without assistance earlier than they otherwise would desire to die so that they can have access before they lose capacity. There will also be workarounds for the baked-in exclusions. Individuals will commit suicide without assistance. Those with money will travel to Switzerland. Some will request and be given terminal sedation, so that is deep and continuous sedation combined with a refusal of hydration and nutrition. Others, as we have already seen in Quebec, will stop eating for long enough to get close enough to death to qualify or to make death certain enough to qualify. There will be battlegrounds as well. Specifically, over the next 2.5 years, there will be independent reviews on the exclusion criteria, the exclusion of mature minors, advance requests, and mental illness as the sole condition. Advocates on all sides of these issues will attempt to persuade Parliament to ensure that the legislation reflects their positions on these issues. Then, if any of these three exclusions remain in the legislation after this review process, there will, without a doubt, be charter challenges, launched on the grounds that the exclusions are discriminatory, for example, on the basis of age or mental disability, and that they also violate the charter right to life, liberty, and security of the person. There is already a charter challenge being made to the baked-in exclusions, specifically to the requirements that the patient's condition must be incurable in an advanced state of irreversible decline in capability and natural death being reasonably foreseeable. Contrast the Supreme Court of Canada declaration on this slide, and that we went over earlier, with the federal legislation. There is no incurable in the Carter Declaration. There is no advanced state of irreversible decline in capability in the Carter Declaration. There is no reasonably foreseeable in the Carter Declaration. So included in the Carter Declaration, and as will be argued in court, required by the Charter, but excluded by the legislation, are the following. Someone's had 3 unsuccessful rounds of chemo, refusing a 4th, not incurable. A traumatic injury, stable 5 years ago, no degeneration. Chronic obstructive pulmonary disease, death is too uncertain. Parkinson's, ALS, MS, Huntington's, when death is too far off. And even Kay Carter at 60 instead of the 89 that she was, death is too far off. The charter challenge is being brought by Julia Lamb. This is a young woman with a progressive neurodegenerative condition. And again, the BC Civil Liberties Association, again on behalf of many others. And they are all represented by the same legal team that worked together on Carter. This challenge will focus on the light orange circle that you see here, those people who the Supreme Court of Canada said in Carter must not be prevented from having access, but who will not have access under the legislation. And with that, I'd offer the final reflections. First, much has been accomplished, and I do have to keep reminding myself of that on dark days. The majority of those who are likely to ultimately desire medical assistance in dying are included in the legislation. Approximately 200 people have been able to access medical assistance in dying to date. And an unknown number, but obviously much, much higher than the 200, have been comforted to know that medical assistance in dying would or will be available to them should or when they reach the point of enduring an intolerable suffering. They may get the prescription but not ultimately use it. They may make the request and qualify, but not ultimately trigger it. And they may never make the request, but simply be relieved to know the option is there to pursue. But still, much remains to be done. And basically all I can say is come back in 2 years, see whether we've realized our very real potential to have the best system of medical assistance in dying in the world. I honestly don't know whether we will, but I'm absolutely certain that we can. So with that, I welcome questions and discussion.
Thank you very much, Jocelyn. We do have a few minutes for questions or comments. Yes. Just if you can just identify yourself when you make a comment.
Dave Spence from Western. I wonder that these legislators passed their English course. A person cannot be there. That's kind of a jokey thing. But the thing that I wonder about is how on earth can anyone's death not be foreseeable? We're all going to die. So that's a silly clause.
Yeah, when I first saw the legislation, we were in a technical briefing, and I almost fell off my chair. I was so surprised by it, for exactly reasonably foreseeable. It's beyond reasonably foreseeable. It's certain. And the thing is, what they did was they played with predictability, which is certain, and they got all messed up in that. What they were trying to do was prevent access for certain people, but without saying it explicitly. Here's an example. They didn't want to say if you have a mental illness, you're excluded, because that's just a straight up violation of the Charter, Section 15. It's just a slam dunk. So they say, oh, let's make it be that it has to be reasonably foreseeable.
It really meant imminent.
Pardon me?
It really meant imminent.
Yeah, but they didn't want to do that because, of course, they'd received an awful lot of input on why it should not be imminent. Why should you have to be have your death be imminent? And so they invented this expression, and I will say that the colleges of physicians and surgeons, the regulatory colleges from across the country fought against that. They argued for that provision to be taken out because they said we cannot govern to that statement. What does it mean? How it's certain, or how far is too far, and so on. The Canadian Medical Association backed up the government on that. And since then, just recently, I've seen is walking back from their embrace of the expression, because what does it mean? And we're having people are going to have trouble implementing it because of that. So there's two problems with it. One is it's difficult to implement, and the second is what's the justification for limiting it in that way?
Lots of questions.
Mm-hmm.
Thank you. I'm Ivy Bergeau from the University of Ottawa. Thank you for that overview. I wanted to sort of highlight a key point, and this was raised by Andre Picard in a recent op-ed, was the issue about the data and not keeping track of that. And I actually find that inexcusable that they're not keeping track of this. So, what's going on there?
What's going on there? A couple of things. Part of it is the federal provincial division of powers and who can say what needs to be collected. So medical certificates of death, for instance, are provincial. So the feds can't tell them what needs to be on, and yet medical certificates of death is the best place to put the data to then be able to do your studies. So part of it is that challenge. Part of it is they chose not to create a commission on end-of-life care, a national commission on end-of-life care, which would have been tasked with doing this as part of its work and been able to do it. Chose not to go there. There is a protocol for doing this that has been drafted. It's been drafted in collaboration with the researchers in the Netherlands and in Belgium who've been doing this for years and years and years. It was just unsuccessful at CIHR. As many things are. And the researchers who can design the protocols, are they being called to Ottawa? So far, no. They're knocking on the door, but so far they're not. So I agree with you. It's inexcusable, and you could say, oh, well, the legislation only passed in June. We knew this was coming. We knew we were going to have to do this, regardless of where you ended on the nuances of the eligibility criteria. You knew you were going to need to do this data collection. It's hugely important. There's no excuse. Judy.
Judy Ellis, University of British Columbia. Jocelyn, that was an exquisite update. Thank you. I was wondering if you could just briefly elaborate on the question of competence. Mm-hmm. What are the instruments that have been considered for assessing competence, either in the adult population, but also in the mature, let's say, capacity competent population who might be asking for this kind of assistance?
Mm-hmm. So what Justice Smith, who wrote a brilliant decision in Carter, if you haven't read it, I commend it to you. It's long, so save some time, but it's actually very accessible. One of the things she noted, and it's repeated in all the reports, is that healthcare providers make capacity assessments every day, and that this should be a part of that. We don't need something new. We don't need something different. That said, it's still subject then to the challenges that we have with capacity assessments. We are not perfect on them at all. The instruments are not perfect. The education of healthcare providers is not perfect. So it's not perfect, but it's to say they're not perfect for anything, for refusals of treatment, for major surgical decisions, for all kinds of decisions that have life and death implications, but we work with them, and so we have to work to constantly improve them, but we don't do anything different. This must belong in the physician-patient or the nurse-practitioner-patient relationship. They do those capacity assessments and so on. I think this will be a piece of the conversation in the reviews, and this is a place for people to engage, is the reviews that are going to happen on mature minors, on mental illness, and on advance requests. That is going to be a piece of it, is how do we do capacity assessments in these more complex contexts. So some mature minors, it's more difficult. More mature minors than adults, it'll be more difficult, but not all, right? There are 17-and-a-half-year-olds whose capacity is far easier to assess than an 89-year-old. So we can't make these categories, but it's going to come up in there. And then in the mental illness, one of the reasons a lot of people say, oh, it can't be mental illness is the sole condition because we can't do the capacity assessments. We do. They may be more complex, but they are not different in kind. And so we need to just continue to work on them. So it fits within the established rules.
Time for two more questions, Dan.
Dale Laird, Western. I noticed the words pain and unresolvable pain is not in any of the text. Where does that fit into the equation, or does it at all?
Yeah, it's because suffering is considered a broader term. They consider pain to fall within suffering. And historically, people always talked about, you have to have intolerable pain. And people realize that a lot of people are actually seeking assistance and dying. It's not because of pain, rather it's because of suffering. So, for instance, extreme breathlessness or extreme unrelievable nausea, the broader category. So it is absolutely front and center. It is a condition. Enduring and intolerable suffering, pain is believed to be inside suffering. So I think that was actually a good thing that they did.
Diane Finegood, Michael Smith Foundation. I wonder if you would speculate on the political rationale here. I know that might be pushing you, but I've often wondered whether the political rationale was we need more public discussion on some of these more difficult issues, so let's leave these things out of the decision so that we had a period of time for more debate.
Yeah, I'm sympathetic to that in relation to mature minors, advance requests, and mental illness as the sole condition. While I am conceptually ready to go there, I actually agree pragmatically. You can absolutely argue that we weren't ready to go there. But in terms of how, the how of it, not the whether, but the how. And so having these reviews, I think, if that's all that it was, I would have been standing up and cheering the legislation, saying, okay, it's more cautious than I would be, but go for it. What I think is unacceptable is the limit on the grievous and irremediable suffering that they put, the incurable declining capabilities, and especially the natural death is reasonably foreseeable. Kay Carter would not qualify under this legislation. Kay Carter of Carter v. Canada. So that notion of you go slow, that is part of what they argued. Okay, go slow, people need to be on side. There's two problems with that. One is people are on side, that the public is ready for the Carter Declaration, not the legislation. And the second is they're just not allowed. The Supreme Court of Canada ruled, and it's not to say something, they tried to muddy it by saying, well, we don't have to follow Carter. It's not, no, but you have to follow the Charter. And Carter explained what the Charter requires of you. And Carter drew a circle and said, the Charter requires that everybody inside this circle have access. You can put in place regulatory frameworks, so all the procedural safeguards, you get to do that, but you don't get to shrink the circle. So that's where that they wanted to say it, and I won't buy that. Over here on the other issues, I do accept that we can take the time and do it carefully and do it well, and would invite everyone to engage in those conversations, because those are going to affect many, many, many people. Imagine the advance requests. Those are when you make the request in advance of loss of capacity. That's going to affect us all. So, and going back to your data point, this room, engage on the data.